Νίκο, ελληνικά θα μιλήσω,
Δεν νομίζω θα καταφέρω. Sorry again, the presentation is in English. It's a very controversial topic, so and especially after such an excellent presentation from Christina, I'm sure that everyone would have a problem to justify the role of laparoscopic surgery in early ovarian cancer. I'm not trying to advocate that all early stages of ovarian cancer should be managed laparoscopically, but I agree with what Christina said, that we should individualize the approach. So I'll give you a brief overview of the staging procedures, the technical concerns, limitation with laparoscopic surgery, and if there are any data regarding the safety and the outcomes. Imagine this clinical scenario, a young patient undergoes a laparoscopic unilateral salpingo-oophorectomy for an ovarian mass. We didn't suspect cancer, and the mass is removed using a bag and is emptied outside the port, and there is no intraperitoneal spillage. I don't know why on the previous presentation they had a 5 centimeter cutoff, but let's assume that this patient undergoes that type of surgery. Histology showed high-grade serous carcinoma, and in this patient we do a CT scan, and the CT scan shows no evidence of metastatic disease. So the question is, what do you do on this patient? Do you do a laparoscopy or laparotomy? Do you remove the other ovary? Do you do hysterectomy? Or do you do a hysterectomy, remove the remaining ovary, and omentectomy? So what we will, that it's important that this patient needs to be staged properly. At this stage, it is 1A disease. However, that there is value in performing a complete staging because we will be able to offer the appropriate treatment recommendation to the patient. As we know, in up to 30% of the cases, there is upstage, so it has prognostic implication for the patient. It has research benefits because the patient can be recruited in trials or can be given new treatments, and it may have an impact on survival, but at the moment we don't have any data to support the survival advantage. So what do? We do peritoneal cytology. We take peritoneal biopsies, and the GOG manual suggests that you need to take 6 random biopsies at least from the pouch of Douglas, UV pouch, paracolic gutters and hemidiaphragms, and also take biopsies from any suspicious areas in the abdominal or pelvis. You do an omentectomy, we do lymphadenectomy, pelvic and para-aortic, hysterectomy and remove the remaining ovarian tube, and do remove the appendix, controversial that also. So in 2004 there was this review that showed that in about 20 to 85% of the patient you can have negative peritoneal cytology even if you have disseminated disease. That did not include only ovarian cancer cases, it had other peritoneal cancers also. There is also debate about the value of omentectomy. I agree with Christina's approach. It's very, very difficult to do a total omentectomy laparoscopically. However, what is called total omentectomy, it varies between studies. And in open surgery, until now, there was no standardization of the surgical technique. So someone used to call an omentectomy total omentectomy. As you heard, a few months later, she had recurrence of the splenic hilum, and there was because the omentum was left there. The GOG surgical guidelines, American guidelines, suggest that you need to do careful inspection of the omentum and at minimum to perform an omental biopsy. However, they don't clarify how big should the omental biopsy be. And that is because of the inconsistent surgical practice, so they can't draw any recommendation. There were a couple of studies that they showed that if you take 3 to 5 samples on an omentum, that will give the accurate diagnosis. So you don't need to take 15 samples from a mental specimen. So then these were studies that they were done by pathologists. So if you extrapolate the same result, then you can say that why don't you take 5 random biopsies from a normal appearing omentum? That probably will give us the same result. Still, this is just an assumption, and it's based on this very limited retrospective data that we have. Also removing a normal appearing omentum that can have implications, as some studies suggest, for the immune response of this patient to the tumor. If you do peritoneal biopsies, yes, we do random peritoneal biopsies. Is there any value of performing these biopsies? And has been shown that if you can upstage of early ovarian cancer based on peritoneal biopsy alone in up to 1% of the patient. So the rest of the patient that they were upstaged had metastatic disease on the lymph nodes or on the omentum specimen. The same were shown by the group in the States, and they suggested that the treatment in their patient group was altered only in 5 out of 1,000 patients based on peritoneal biopsies alone. So they still say it is an easy procedure to do, why don't we do it? And we can do this, this can be done laparoscopically. This is another study that suggested that if you do omental and peritoneal biopsies, you can upstage up to 4.9% of the patient. However, it wasn't clear from this paper if they did systematic pelvic and para-aortic lymphadenectomy, because they didn't have any stage 3C tumors at that time. So probably they didn't do lymphadenectomy, so they just, the staging procedures did not include a lymphadenectomy. The rationale for appendicectomy is based on data, still retrospective data, and the reason why we do this is to upstage ovarian disease in serous tumors, to rule out an appendiceal primary that we may find in mucinous tumors, as you know, and that there is more controversial to prevent appendicitis or future complication. Upstaging ovarian disease can happen in up to 10% of the cases when we do appendicectomy. However, this is controversial. There is no upstaging based on disease involving the appendix only, and still we are stopping in our institution performing appendicectomies either for serous or mucinous ovarian tumors. And we stop also in mucinous ovarian carcinoma because we don't think that there are many true mucinous ovarian cancers. The newest studies suggest that it represents about 3% of ovarian tumors, and most of the cases they come either from appendix, colon, or upper GI. And a review of literature suggests that if the appendix looks normal, it is very unlikely that it contains a pathology within the lumen that is responsible for the metastatic disease in the ovary. So we have stopped, even if our pathologists tell us that this looks like a mucinous tumor, we don't perform appendicectomy anymore. So this is the study that Christina mentioned earlier by Maggioni, that the value of performing lymphadenectomy in early stage ovarian cancer, no difference in overall survival or progression-free survival, but the trial wasn't designed to show this first, and second, a patient received chemotherapy even in the lymphadenectomy, more patients received chemotherapy in the no lymphadenectomy group. That there was a study or a retrospective analysis of the data from 17 countries' national registries, and that was published in the British Journal of Obs and Gynae, and it showed that for stage 1 ovarian cancer, stage 2, and for most of the, even for stage 3 and 4, if you do perform a lymphadenectomy versus no lymphadenectomy, that offers a survival benefit. This is still another controversial study. That is the problem with retrospective studies. And the main reason for that is that there is a bias on selection here, and there is no standardization of surgical techniques, and it is retrospective, which is not helpful. A review in Gynecological Oncology in 2011 showed that for early stage, for epithelial ovarian cancer, for stage 1 and 2, the overall rate of metastatic disease in the pelvic and para-aortic lymph nodes is about 14%, more or less what we all say. Only para-aortics is about 7%, and this is if you have only pelvic or both pelvic and para-aortic. More or less the same data as you saw previously. Now, when we go to the histological subtype, if the patient has serous disease, it is about 23% of the patient will have metastatic disease on the lymph nodes. And here it comes when we talk about mucinous tumors, in about 2.6% of the cases, you can have metastatic disease if the tumor is mucinous. The problem, there are two main issues here. So if you do a frozen section to approach patient with early stage ovarian cancer, often the pathologists are not very good in telling you between mucinous and endometrioid tumor. So you are not sure if you are in the mucinous group and you should avoid the lymphadenectomy, or you are on the endometrioid type tumor, so you need to perform lymphadenectomy. Another problem with these studies is that these are retrospective data, although this is a review of the retrospective data. These are retrospective data, and what they were called mucinous tumors in the past, if we had to go back today and examine these tumors, we'd find that very, very small percentage of this tumor would fit the criteria. So they would fit the criteria for mucinous tumor being of ovarian origin. So most of these tumors were of bowel origin that, with the knowledge that we had at those days, we used to classify it as mucinous. So still, in our unit, when we do frozen section for ovarian masses and the pathologist suggests mucinous tumor, we still perform pelvic and para-aortic lymphadenectomy, but we look forward to see newer data. So regarding laparoscopy, it's not possible to perform, as I said at the beginning, in all patients with early stage or suspected early stage ovarian cancer. It is feasible, yes. It has technical limitations, and there are safety concerns, and there are a lot of unanswered questions. And as I said, I'm not advocating that it should replace laparotomy. So we can do most of the procedures apart from total omentectomy laparoscopically. We can take biopsies, we can remove the ovaries, we can visualize the pelvic and abdominal peritoneum. There are some difficulties on the Morrison's pouch, and difficulties on the lesser sac. But the main concern is, can we match what we do in open surgery in removing the para-aortic and pelvic lymph node? I'm not sure about that. So lymphadenectomy is the only limiting factor. But if there is surgical expertise, you probably can overcome this. Still, the number of lymph nodes may not be the same. I want to show you this video was because we're playing with the new device. So I just want to show you. So we have cleared the tumor from the lymph nodes from the aortic bifurcation. This is the IVC. We have removed the lymph nodes from the psoas muscle. We have cleared, as you can see, that this is the spine here, the psoas on the left side, and the left side is the limiting factor for most laparoscopic surgeons. You can see the IMA, you can see the ureter, and the kidney that it's here. All this fat belongs to kidney. That's the renal vein, and we have pushed this. Yes, that there is tumor here. Yes, I agree. There are lymph nodes there left. Yes, I agree, but does this meet the surgical outcome? So is it worth on a young patient that we've done previously laparoscopy to put her through a laparotomy, or are we happy that we have achieved what we have achieved with this approach? And as you can see, that even the infrarenal lymph nodes on the left side are removed. This is the prerenal fat. So what do the data show regarding the limitation and safety? There was a Cochrane database review, but it's one of those reviews that you often read. Yes, we did the review to find the value to compare laparoscopic versus open staging in ovarian cancer, and we didn't find any randomized controlled trials, and they come with the conclusion that we don't know what is going on at the moment. But these were some of the older studies. As you can see, they started in '94. Kerla and Pommel. They did staging for women with what they thought it was early ovarian cancer, and the data continue till recently. But these were single arm studies, so they didn't compare it with laparotomy. And what they showed is that they have a relatively high number of pelvic lymph nodes. The para-aortic lymph nodes, there are mean number of lymph nodes is 10 lymph nodes. I believe it's very low, the node count from the studies. There was a meta-analysis in the studies that compared the laparotomy versus laparoscopy. So they had cohorts, they were retrospective cohorts, and what they showed is that if you do laparoscopy, you have less blood loss. You can upstage up to 22% of the patient, which is more or less what the literature suggests. You have a quite high conversion rate, and recurrence rate, it's about 9.9%. There was a lot of criticism about this meta-analysis. The numbers were small, and that there were a lot of authors raised concern about safety. So if there is a cyst that is 15 centimeters, we wouldn't attempt to do a laparoscopic procedure. So as gynae oncologists, the aim is the safety of the patient and assuring that the appropriate oncological outcomes, so we wouldn't attempt a laparoscopy. If we think that we can remove the ovarian cyst without spillage laparoscopically, then we would do a two-step procedure. Because there is no point of doing a frozen section, the logistics of booking a theater and booking the pathologist and the false negative and false positive value of frozen section, we prefer to do it as a two-step procedure for small ovarian masses. Large ovarian masses or masses that are at risk of rupture, we would do a laparotomy. So there are concerns that comprehensive surgical staging is not possible, as I mentioned previously. It has to do with removing the lymph nodes, and also it has to do with inspection of peritoneal cavity. I have to agree with Christina that you can't inspect properly the peritoneal cavity. However, if you combined the findings on CT scan with your laparoscopic assessment, probably it is you are doing appropriate job. So there are no data to show how many cases you're going to miss compared to laparotomy. There is this theory that there is increased risk of metastasis or recurrence. Yes, there is. This is what has been assumed, and there were studies in animal models that they showed that if the CO2 has an effect on the peritoneum and it lowers the pH. And if it lowers the pH, that increases the mitotic rate of the tumor. So you have more chances that this tumor that if you have cells in the peritoneal cavity, this will metastasize. Also, there was the theory that because laparoscopic procedures are longer, you have prolonged damage to the mesothelium, and that increases the risk of metastasis. There is also the debate about the port site metastasis. It occurs in about 1 to 2% of laparoscopies. I think this study was by Pedro Ramirez in MD Anderson, and they found that when they reviewed the literature, about 1 to 2% of the cases, they will have metastatic disease on the port. We don't know exactly why it happens. It's probably poor surgical technique, or it is a chimney effect. So when you remove the port and there is some gas that comes out and pushes the cancer cells and they implant on the port. It is more likely if you have metastatic ovarian cancer, so disease in the peritoneum. It is less likely, as the authors agree, if you have stage 1A disease. What can you do for this case? Some authors use betadine. I heard it on a previous presentation, so they clean the ports with betadine. Others, they excise. They are a little bit more radical, so they excise the ports at the end of the laparoscopic procedures. The authors agreed that this is equivalent to laparotomy regarding wound metastasis. It happens in laparotomy. Probably in laparotomy, I would say it is bad surgical practice. In laparoscopy, it's a little bit more. It's bad surgical practice and the chimney effect. So there are limitations. As I mentioned, large ovarian masses, we can't do it laparoscopically. Obese patient, you can't assess the peritoneal cavity laparoscopically. Also, you can't assess the para-aortic and pelvic lymph nodes laparoscopically as well as with a laparotomy approach. So in obese patient, yes, there is a value of doing extraperitoneal para-aortic lymphadenectomy. Then go transperitoneally, you assess the peritoneum, you take omental biopsies, and you complete the staging procedure. And also, if there are anesthetic concerns, the newer peritoneum makes this worse. So it is this limit the laparoscopic approach. So to summarize, the laparoscopy, it is feasible it is only for early stage disease and in patients that we are unlikely to cause rupture of the ovarian masses. It is so for selected population only. The surgical expertise, it is paramount, so you can't do staging in ovarian cancer without appropriate expertise in open surgery and laparoscopic surgery. And at the moment, I can't give you any data regarding the safety of the procedure because there are no data. And I believe that it's going to be very, very difficult to find data in comparing these two procedures because it's very difficult to standardize surgical practice and in early stage ovarian cancer and in advanced stage ovarian cancer. So thank you very much for listening.
Thank you very much, Dr. Burbos. That was an excellent presentation on the spot. Should we ask questions now or proceed with the next? Μάλιστα, ναι, κύριε Ροδολάκη.
Thank you very much, Dr. Burgos, for the excellent presentation. Let me ask you, what's your policy in your center when you have to manage a patient who accidentally found to have an ovarian tumor and treated by laparoscopy, either inadequately or intraoperatively ruptured, and is a grade 1 or 2, who otherwise, if he was treated properly, we wouldn't give anything adjuvant treatment. Do you stage the patient? Do you give chemotherapy to that patient based on the fact that the intraoperative rupture of the cyst was done?
Yes, if it is, thank you. If it is just based on that there is controversy about if stage 1C merits the same the same attention, if the surgical 1C based on surgical rupture or it was on peritoneal fluid. So in our center, we do full staging. So we go back, we do a CT scan first of all, then we do a laparoscopic assessment if there is no evidence of metastatic disease, laparoscopic assessment and full staging. We've been caught in few cases because we receive patient from other centers, and what happened is that the patient came to us, we went to do laparoscopy, and we found that they had metastatic disease, that it wasn't reported because the surgeon that did the first procedure, they were not gynecologists, so it was underreported, the disease. So in those cases, we converted to laparotomy, and this is what happens. But the second question is if you are going to give chemotherapy to this patient.
What happens if everything was negative in your staging? You do your staging, everything is negative, and would you give chemotherapy based only on the fact that intraoperative rupture was done?
It varies on the oncologist. When I was when I was working in Ireland, they used to give chemotherapy, so they didn't used to take into account staging. So for 1C, they used to give chemotherapy. In our case, we tend to individualize the treatment. So if it is negative, then our oncologists have preference based on some of the older data to give carboplatin alone. I don't know if that is how much data is to support that. I don't know if you have any idea, Christina, but our oncologists, they give carboplatin alone. And we don't know exactly what is the value of complete staging. Does it have a therapeutic benefit? It might have a therapeutic benefit, still difficult to predict. Or is the complete surgical staging that we can tailor the adjuvant chemotherapy? But until now, that we don't have any data on that. So, but our oncologists, to summarize, so we'll do complete staging, and if everything is negative, they will give carboplatin alone.
But the only data we have are the action and icon data.
Yeah.
Show that the adequately staged patients who received chemo had a better prognosis than the inadequately staged patients who didn't receive chemo. But of course, that wasn't a planned analysis. It was just a retrospective, subboard analysis. But yeah, I think in stage 1C disease,
Yeah.
so in stage 1A, 1B, grade 3, carboplatin mono is enough, but
Yeah.
Bradley Monk has done big meta-analysis in 1C disease with intraperitoneal rupture, especially in laparoscopy and bad practice where, I mean, we can have really bad dissemination of cells, that you actually need a combination treatment. But again, retrospective data.
Yeah.
Again, retrospective data.
Thank you.
May I make just one comment? Even in the last staging in 2014 of ovarian cancer, intraoperative spillage was substage to 1C1. So that also makes a point that maybe there's a difference in overall survival. Okay. So let's move on. Thank you very much.